Good morning, everybody. It's a great pleasure for me to introduce Stefanie Hehl, who is presenting a talk about functional syndromes after esophagectomy. Thank you.
Thank you. Good morning, everyone, and thank you, Professor Gucha, for the kind introduction. Today I'm going to talk about functional syndrome after esophagectomy, and I want to start with a brief overview over esophageal cancer, which is the 8th most common cancer worldwide, accounting for around 3% of newly diagnosed cases every year, being the 6th most common cause of cancer death. Over the last years, we saw an increase in the survival rate, which is due to the introduction of multimodal therapy options, such as neoadjuvant chemo and radiochemotherapy. And we do have a 5-year survival rate of around 20% right now, versus the 1960s and 70s, when we only had a 5-year survival rate of 5%. What does that mean? It does mean that with a increased long-term survival, and esophagectomy is still playing the key role of the oncological therapy, we do have a growing number of patients actually living with a surgically altered anatomy, becoming more and more important that we actually pay attention to the postoperative functions and syndrome that occur in patients after esophagectomy. I want to give you a brief overview over the surgical aspect, and a proximal located tumor in the esophagus does require for a subtotal or total esophagectomy, with the reconstruction of the digestive pathway being by mobilizing a gastric conduit into the thoracic cavity and creating an anastomosis to the remaining part of the oral esophagus. Unfortunately, less than 20% of patients after esophagectomy do present with a normal alimentary function, and the most common syndromes after surgery being dysphagia, reflux, delayed gastric conduit emptying, and dumping syndrome. To start with dysphagia, it is presented in 46% of the patients after esophagectomy, yet 3 to 4% of patients do present with severe symptoms. The main underlying cause is an anastomotic stricture, with an incidence described between 10 and 50%. And the pathophysiology that lies behind it is not well understood yet, but what is believed to be the cause is a local ischemia and high tension on the anastomosis that actually causes a local inflammation followed by a formation of scar tissue. That actually explains the risk factors that we do have or do know, and that is a anastomotic leakage, neoadjuvant therapy, and then a couple of diseases that actually do influence the wound healing, such as cardiovascular diseases, a BMI over 25, diabetes, and smoking. And if we do have a new onset of dysphagia after a longer term of follow-up, we do have to consider the reflux actually causing peptic strictures of the anastomosis, as can be seen in the picture. The diagnosis is basically made by endoscopy, which allows a macroscopical view on the anastomotic and the stricture, and by contrast imaging. The therapy, which I'm going to show a picture of later on, is the standard by balloon dilation, which actually means for our patients that they have to undergo multiple endoscopies, because in order to prevent a complication such as perforation, the anastomotic stricture is only dilated by 3 millimeters each time. And once we have reached a width of the anastomosis of around 16 millimeters, it is described that the patients can actually tolerate solid food or a normal diet again. To talk about the next syndrome, which is reflux, that occurs in 60 to 80% of patients after esophagectomy, including symptoms like heartburn, regurgitation, and chronic cough, especially when the patients are laying flat or after having meals. And the causes of that are a loss of the natural anti-reflux mechanisms or barrier, and a transposition of the gastric conduit into the negative thoracic pressure zone, meaning that we have an abdominal, a positive abdominal pressure that promotes the reflux into the negative pressure zone of the thoracic cavity. What is also very interesting is that we do see a regeneration of the acid production in long-term follow-up of the gastric conduit. And Professor Gucha published a study in Annals of Surgery that actually showed that the denervated stomach or gastric conduit was able to almost fully recover its acid production. And after like a 3-year follow-up, we did have a 97% of regeneration of the acid production. To diagnose or actually monitor the severity, we do have a score by Villanovic that is called the GERD, Health-Related Quality of Life Score. And it's basically a questionnaire to monitor the severity of the syndromes and is asking questions like how bad is the heartburn, how often does it occur, does it wake people up from sleep, which is very important for us to know that our patient is not only suffering from reflux, but also that we know how badly it actually disables them in their daily life. Then diagnosis is made by endoscopy, which obviously allows biopsies and histological clarification, as well as ruling out a tumor reoccurrence. And a long-term pH metry can be performed to underline the diagnosis. The therapy, the baseline is technically to reduce or inhibit the gastric acid production, and that is done by a high doses of PPIs and H2 receptor antagonists that can be added. And we do have to rule out underlying cause that causes secondary reflux, just as delayed gastric conduit emptying, which brings me to the next topic. That occurs in 10 to 20% of patients and does include symptoms like early satiety, reflux, vomiting, and thoracic pain, and is caused by a dysfunction of the intraduodenal motility, which is not quite understood mechanism behind it, but what is believed to be the cause is that the denervated stomach and pylorus, as well as the when we do the lymph node dissection during the surgery, that disrupts the sympathetic input and therefore has a dysfunction or causes a dysfunction into the motility. As well as individuals, we do have the volume, diameter, and a possible kinking of the gastric conduit actually taken into that play and causing a delayed gastric conduit emptying. The diagnosis is made by endoscopy and contrast or X-ray imaging, and to the left side you see an X-ray of the chest that shows a very characteristic pattern, which is a dilated conduit and air fluid levels that actually speak for the diagnosis of a delayed gastric emptying. And to the left side you can see the picture of the endoscopy, and what we do see is that we have residual food left in the gastric conduit after a longer period of fasting. Although what is not described is that we do not have cutoff values in terms of like how long the patient needs to be fasted and how much residual food there actually needs to be in order to diagnose it. In unclear cases, a gastric scintigraphy can actually be performed, and that is done by intaking a meal that is labeled with technetium. And after a period of 180 minutes, it is measured, the activity is measured, and if there's an activity over 50% left, then that is actually very likely to be caused by gastric delayed emptying. The therapy options reach from pharmacological to interventional to surgical aspects, and the pharmacological ones being prokinetic agents, just as metoclopramide that we use or almost use on a daily basis, and erythromycin, which is a macrolide antibiotic that actually works on the motility receptor, and prucalopride, which is a rather new drug developed for chronic obstipation, and it is actually a serotonin receptor agonist that accelerates the gastrointestinal motility. Interventional options, and I'm going to show pictures of that in a second, is the balloon dilation of the pyloric region and the gastric per oral endoscopic myotomy of the pylorus. In refractory cases, a surgical approach can be made that is done in our hospital, and it is the diversion of the conduit with a jejunal loop via Roux-en-Y. This is a picture of the balloon dilation of the pylorus, and it shows the pyloric region on the left side, and then the inflation of the balloon and the dilated area of the pyloric region, that we can actually now have an easier passage of the bolus into the small intestines. And this is the endoscopic myotomy of the pylorus. And what they do is they do make a small mucosal incision into the antrum of the pylorus, create a tunnel into the stomach wall, and then get to the pyloric sphincter and cut little strips of muscles from the pyloric muscle to actually get to like a widened part so that we can have an easier passage into the small intestines. The next syndrome I want to talk about is the dumping syndrome that occurs in 18 to 50% of the patients, and it is mainly caused by a reduction of the gastric reservoir or capacity and can be clinically divided into an early onset form, which occurs in 40 to 70% of the patient, and a late onset form, which occurs in 20 to 40% of the patients. The main underlying cause is that basically due to the reduction of the capacity, we don't have like the pre-digestion that usually happens in the stomach. So what will happen is a rapid flooding of the smaller intestines like the duodenum and the jejunum of like unfractioned big portions of food. And then the hyperosmolar contents in the jejunum will actually cause a shift of fluids. So the fluids is actually going into the lumen and causing symptoms, systemic symptoms like hypovolemia, hypotension, along with tachycardia, palpitations, and the distension of the wall of the intestines actually causes the release or increase in gastrointestinal hormones that add on to other symptoms like abdominal pain, bloating, and diarrhea. The early onset form occurs 10 to 30 minutes after eating, while the late onset form of dumping syndrome occurs around an hour to 3 hours after eating and is mainly caused by the rapid absorption of glucose that then causes a hyperglycemia followed by like an increase in insulin secretion and then actually causing a reactive hypoglycemia with the ongoing symptom as fatigue, weakness, hunger, and palpitations. And the diagnosis is made by a typical constellation of symptoms and an oral glucose challenge that can be performed to actually underline the diagnosis. We do have a scoring system, which is called the 6-dot scoring system, that actually rates the symptoms by their likelihood, and it adds up to a score. And if the score is more than 7, it is very suggestive that the dumping syndrome is the underlying cause for the symptoms. The therapy is basically dietary modifications, and we do recommend our patients to see nutritional experts. And by that, they usually recommend that the intake of carbohydrates should be reduced. Patients should take like smaller meals and more frequent meals, so it is recommended to have at least 6 meals over the course of the day. And fluid intake should be reduced while eating. 3 to 5% of patients are refractory to dietary modifications, so we do have pharmacological aspects. One of them being acarbose, that actually reduces the intake or the resorption of glucose in the small intestine, such as a dioxide, which actually has a very interesting mechanism or form of mechanism. It works in the beta cell of the pancreas and does open ATP-sensitive potassium channels, which cause a hyperpolarization of the cell that closes calcium channels and therefore inhibits the insulin secretion, which is used for the late onset version of dumping syndrome. Octreotide is a long-lasting analog of somatostatin and therefore actually slows down the gastrointestinal motility by inhibiting the release of gastrointestinal hormones. We do have non-specific post-op symptoms that are just as important as the one I already mentioned, but they don't just classify into the syndromes that I talked about, which is excessive weight loss along with malnutrition, diarrhea, and steatorrhea. And almost all of our patients after esophagectomy do have a certain kind of weight loss. What is tolerated after surgery, 3 months after surgery, is a weight loss of about 10%. Anything that goes beyond that does have to be supplemented with nutritional supplementation, just as like high caloric shakes, or if that is not sufficient, we do recommend the insertion of a small bowel feeding tube. and then diarrhea and steatorrhea that often overlap with some form of dumping syndrome can be treated with motility inhibitors, just as loperamide. This is the summary or the table to summarize, and I want to point out with this table that all of these symptoms or syndromes do have an underlying baseline, which is the comprehensive assessment of symptoms. And it's very important for us as surgeons and doctors to sit down with our patients and, like I mentioned before, talk about their symptoms and how it actually affects their quality of life and their daily going through the day. We do have a lot of scores and questionnaires that help us with that. And I just wanted to show that like endoscopy is for most of the syndromes the main way to diagnosis, and that nutritional counseling is the underlying baseline for the therapeutical treatments for all of them. Coming to an end to today's lecture, I want to emphasize again that esophagectomy is a life-altering surgery, and the functional disorders can be very disabling for our patients, and it therefore is very important for us to actually bring more attention onto these syndromes. If we think about it, for us, like eating seems like a very easy and natural thing, but for most of the patients, after esophagectomy, it can and most likely will become a daily struggle in their everyday life. And most of the patients will never eat again the way they did before surgery. So the key to a long-term or successful outcome for our patients is that we have an interdisciplinary therapy that we do with, as surgeons, with nutritional experts, also gastroenterologists and oncologists. Thank you very much.
Thank you very much for this excellent review, important topic. I think it shows that when surgery is successful, esophagectomy was associated with high mortality, morbidity, so we were focusing only on what we can see. And now we have to focus on quality of life, which is what is most important for the patient. So you highlight that very well. It's important for the informed consent. Patients need to know before surgery, whatever that is, what's happened later on, even if this is successful. And also, as you mentioned, for the internist or every doctor who follow these patients. Maybe a question I have is for Professor Guccio. Where's Professor Guccio? Here. I mean, as a surgeon, is there any, probably it's also related to technique, these things. It's not just quality of surgery, may match also quality of life. So just maybe a few words, what can we do surgically to minimize, totally prevent, I understand it's not feasible, but can we minimize some of these long-term or mild-term or intermediate-term complications?
Yeah, thank you for this question. This is a bit difficult to answer because most of those syndromes are difficult to diagnose, and it's even more difficult to deduct from the symptoms to surgical details that may lead to those symptoms. I think what we know today and what most experts agree upon is that if we perform a gastric conduit reconstruction, the conduit shouldn't be too large regarding its diameter. Okay, so emptying is much easier of the conduit if the diameter is smaller. This has some physical physics that on the basis of that. In earlier times, some surgeons preferred the whole stomach for reconstruction, but this empties very slowly, so smaller diameters. I think in terms of minimally invasive surgery, robotic surgery, there has been no change since 70 years, since the basics of this type of surgery have been installed. There's also a major discussion regarding intraoperative pyloroplasty to facilitate gastric emptying. This is very debated. We have shown in an earlier paper that gastric emptying is better if you combine some form of pyloroplasty or pyloric drainage with a prokinetic such as erythromycin, which acts on the stomach. But only the combination of both in our study, in our clinical study, really achieved more rapid gastric emptying. But if with more rapid gastric emptying, you're in danger to enter the problem of dumping as well, you know. So it's always an equilibrium that you have to find, and also the patient has to find. Most patients have most problems early after surgery, and quality of life increases up to 12 months, 15 months, and then you can say, okay, the patient has the optimal quality of life he can achieve with that type of surgery. It's interesting that after extreme long-term follow-up, more than 5 years, in my view, quality of life even deteriorates because the surgical reconstruction tends to relax, the stomach is redundant, and then it starts to deteriorate again. And then we might have indications also for new gastric surgery, such as Roux-en-Y drainage of the conduit. It's a very complicated topic, but it's very important that we have this, as you emphasized, interdisciplinary approach with nutritional counseling and gastroenterologists especially.
How do you usually perform your anastomosis?
Anastomosis, yeah. There are different techniques around. We use a minimally invasive thoracoscopic approach for intrathoracic anastomosis, and there we prefer end-to-side staples, 28 millimeter circular stapler. And the anvil of the stapler, we don't use the double stapling anymore, which was the oval technique with 25 millimeter. We do a hand-sewn purse string suture at the esophageal stump to insert the anvil, and then we perform anastomosis with the 28 millimeter stapler, which creates quite a large anastomosis and very standardized.
Okay, thank you very much.
Thank you.